Welcome to Access Points. I'm Mike Gibson, and I'm joined by Rasha, Al-Ramee, and we are here with the final day wrap-up on Monday. A lot of exciting stuff today. For me, again, the most exciting stuff was some Crispr news. I mean, yesterday we talked about the Crispr news of editing the TTR, bringing down that protein by 90% in amyloid patients. Today we're hearing about PCSK9 inhibition in non-primates. Talk to us a bit about that.
Yeah, I thought this was fantastic. It's obviously not an expert, I'm not an expert in this field, but I really think this is the way things are going. So we heard from a study that looked at non-human primates and told us that PCSK9 CRISPR gene editing therapy basically reduced LDL by up to 70%. And this was durable out to 476 days. So imagine a scenario whereby we've got this for patients in the future. And of course, the building block is the first-in-man trial. And we can tell our patients we've got a one-shot and you're done therapy. This reduces your LDL durably, and importantly, it looks like they've done some safety. They've looked at the safety of this editing and seen that there was only a transient rise in liver enzymes, and there didn't seem to be any issue in terms of long-term genetic editing, in terms of sperm cell regeneration, etc. So I really think this could be the future, and it could be a fantastic preventative therapy for our patients.
I agree, we began with once weekly sub-Q injections, then it's every other week. Now, with inclisiran, maybe every 6 months. But here, a one and done that's safe. Let's also keep in mind the cholesterol years phenomenon. It's not just lower is better, but earlier is better. And, starting something like this very early, could be very helpful. So very exciting.
It's super exciting. And I hope that we get to be able to explain to our patients how important it might be and get them on board with gene therapy as a medical advance.
Going to be compliant with gene therapy. Then we saw a lot of resistant hypertension news, drug approaches, device approaches. Talk to us about spiral hypertension first.
Yeah, so this was interesting because I thought SPYRAL ON-MED and the full study was going to show us once and for all that in resistant hypertension patients we might have long-lasting reduction in blood pressure.
This is with renal denervation.
With renal denervation. Yes. Now, of course, we had seen the pilot study data. We'd seen a reduction in blood pressure of 5 to 10 milligrams of mercury. However, we haven't seen that result in the extended study. And that's kind of interesting. The results were kind of a bit disappointing, I guess, for renal denervation. However, we've got to remember that this study was conducted during COVID times, and therefore some of the many visits that they expected and the rigor of the trial was less easy to conduct. And actually what was interesting was that they found that in the placebo arm patients, there was in fact an increase in antihypertensive medication use. So that clearly must have diluted the effect between the renal denervation arm and the placebo arm. And we haven't seen the blood pressure reduction that we might have expected from the previous trials.
Yeah, first of many analyses where we'll be seeing, well, here was the COVID analysis, the pre-COVID and post-COVID analysis. So that's a preview of things to come in the field, I think. And also some drug news, endothelin receptor antagonism for resistant hypertension.
Yeah, so the news from aprocitentan was really interesting. It's a novel agent for hypertension and resistant hypertension. And this was a trial really looking at patients who were already on 3 antihypertensive agents, looking at this new agent as a 4th drug and showing actually a reduction in blood pressure that was significant. There were some side effects, but only edema and something that could really be treated with diuretics, and that was how it was treated in the main. So this could be really exciting news for resistant hypertension patients, giving us a 4th agent we can add in.
Yeah, I mean, again, let's remember resistant hypertension is one of the biggest killers in the world. And for you and I personally thought one of the biggest things here was host exam extended. This is a trial comparing aspirin monotherapy to clopidogrel monotherapy. And they found lower rates of discontinuation with clopidogrel, less bleeding with clopidogrel, lower ischemic events. We're talking about a 26% relative risk reduction here. You don't have to treat 25 people with clopidogrel to prevent an event compared to aspirin. Really raises a big question, doesn't it? I mean, what should we be doing chronically for that chronic secondary prevention? Is it time to move from aspirin over to clopidogrel?
Yeah, so I think this is really interesting again, because we had those results of host exam, the 24-month data. Now we have data out to 6 years. We can see that in patients who were stable and ACS, that if they'd had no events on dual antiplatelet therapy post drug-eluting stent implantation in the first year, if we switched them to clopidogrel monotherapy as opposed to aspirin monotherapy, they seem to have less bleeding and less events over long term. So maybe that's the future for our patients, right? And in secondary prevention, what we should be expecting in the long term post PCI is clopidogrel monotherapy in our patients. And I think that's maybe a moment to reconsider and switch.
And, you know, I hate to say this, but, you know, maybe we need to re-examine things in light of high-dose statins, PCSK9 inhibition, everything else that we're doing out there. Do we really need some of these drugs at all over the long term? So I think things change over time, and newer generations of stents. Well, thanks, Rasha, for joining us. Thanks to all of you for joining us here at Access Points, live from AHA 2022.